So, Assalamu alaikum, dear students. This is the second session on the hips capsulitis shoulder. थोड़ा सा हम रिवाइज करते हैं कि प्रीवियस सेशन में हमने क्या क्या डिस्कस किया था. So we start from the description of the Ehrlich capsulitis, what Ehrlich capsulitis is. Then we discuss on the MR a single characteristic of the Ehrlich capsulitis. This is the chicken joint capsule, which is the cardinal sign on the MR for the Ehrlich capsulitis. Then we discuss what other names they can be used and they can be available in the literature. So that is the frozen shoulder syndrome or the frozen shoulder, the painful stiff shoulder or simple the stiff shoulder, the periarthritis, the shoulder periarthritis or the humeral periarthritis or the your old shoulder and the chair and Japan. These were the codes used for the staphylitis. Then we discuss what are the different causes of etiology. We discuss what we mean by the primary and secondary adhesive capsulitis. What are the three categories of the secondary adhesive capsulitis that may be from the systemic cause, that may be from the extrinsic cause, that may be from the intrinsic cause, and the basis of these causes. The cause is within the shoulder complex sets that will be called as the intrinsic cause or intrinsic factor. And if etiological factor that is outside the shoulder, and that is maybe related to some mechanical tissue related to the cervical spine, the thoracic, yeah, you can say the cardiothoracic region, that may be from any neurological condition like stroke, or it may be from the fracture of the lung bone, especially the hip so in eye and in the Parkinson disease, these will be called as extrinsic factor, and if it is from the metabolic disorder like diabetic mellitus, it is called as the systemic. If it is because of the hypothyroidism, then it will also be considered as the systemic. But secondary to hoga obviously, लेकिन secondary में ये systemic cause हो गया systemic secondary shoulder. Then we discuss about the prevalence of diabetes in general population as well as, and we discuss in the diabetic population. After that, we discuss the risk factor and the red flags. We discuss what is the situation between the skin disease or the contracture and shoulder. We discuss studies from the literature. We discuss the situation between the frontal shoulder and the Parkinson disease. Similarly, we discuss the situation between the hypothyroidism, the thyroid disorder, and the frontal shoulders. All of them they have a strong correlation. These two are again another studies which are supporting the strong correlation between the hypothyroidism and the frontal shoulder. These were the other risk factors and red flags for the adhesive capsulitis. Then we discuss what actually there is, what is the story there in the adhesive capsulitis, what structures that actually involved. That is the anterior superior joint capsule, the exterior vesicle, and the brachial ligament. What are the common historical findings? We discussed them in the previous. Why the sleep subject to examination about the sleep is important. And we discussed the sleep, the pain, and the depression triangle and what is its significance. Then we discuss what are the different anatomical changes which occur during the adhesive in the patients. What are the changes which occur in the joint capsule in adhesive? We discuss the three phases of the adhesive capsulitis. What question should be asked in the subjective history of the patient with the adhesive capsulitis? Then the objective examination. What are the common impairments which we will meet with therapist in the assessment of the patient with adhesive capsulitis? These are the procedures for assessing the different range of motion of the shoulder joint. We discussed the importance of the posture observation and specifically which posture is important to observe. So we discussed that scapular movement should be observed in the elevation, as in the patient in the adhesive capsulitis, when the patient is trying to elevate his or her shoulder, so the scapular movement that start early, that start earlier than the distinctivity of the elevation. Normally, the scapular movement start upward rotation, the anterior tilting, they start after the 60 degree of the elevation of the shoulder, but in case of idiopathic, there is earlier start of this scapular movement. Why the upper quadrant exam is important, and which structure and which component should check of the upper quadrant. We discussed the different procedures and the maneuvers used for the assessment of the brachioradial ligament, the superior middle and inferior glenohumeral ligament, as well as we discussed how the posterior capsule can be assessed. If there is any tightness in the posterior capsule, that was the procedure which we discussed in the previous session. We discussed the shoulder shrug sign. What does it mean? The shoulder shrug sign, and this is again a positive sign in patient and most commonly present in the patient with the adenocarditis. Then we discuss what we mean by the hand tunic and scapula and hand scapula scar. We discuss in detail about the subcoracoid right triangle and subcoracoid triangle sign. Subcoracoid right triangle is a normal structure which is present between the different structures, including the subcoracoid and the control, as well as when during the adenocarditis, that's a triangular structure of made of consist of most fat and lipids is diminishes, and we can say that even there is complete or partial vegetation of this subcoracoid right triangle. The boundary, the superior boundary of this right triangle is the brachioradial ligament, and the anterior superior boundaries are the brachialis as well as the coracoid process, and the posterior end will be the glenohumeral joint capsule. This is the comparison of the MR. The T1 weighted images of the shoulder for normal person, normal subject, which here we can see here a white triangle known as the subcoracoid right triangle, and on the other hand, there is the position of the dash subcoracoid right triangle in this patient. Completely, we can see there is nothing present on this. There is no hyperintensity, while there is clear hyperintensity on this space. So instead of rather than hyperintensity, there is hyperintensity. There is no such whitening at this place. Then we discuss the ultrasound and why it is sensitive and specific. We discussed their sensitivity specific. After that, we will discuss the MR in this session. In this session, we will start from the MR and we will then head towards the treatment as well as the symptoms, the acute, subacute, and the chronic, or we can say the mild adenocarditis. So, what the six characteristics are which can be seen with the MRI on the patient or adenocarditis. The most common of them is the subcoracoid red position, which we call it subcoracoid triangle sign. We discussed them in detail in the previous session. Another feature which can be on the MR, the abnormal feature in the patient with the adenocarditis, that is the thickening of the coracohumeral ligament. Similarly, there is also thickening of the rotator interval, and there is hyperintensity of the ligament complex, specifically the rhesus, which is that axillary rhesus or the axillary pouch, and there is the thickening of the ligament and ligament complex as well. What is the criteria on the basis of the abnormal features on the MR? How we can decide that the person is with adenocarditis? There is no chance of adenocarditis. There is no such condition present in this. So, if the thickness of the capsule is greater than 4.5 millimeter in the axillary rhesus, most commonly thickened in patient with adenocarditis, or if the rotatory interval thickness of the rotatory interval is more than 6 millimeter, in both cases, criteria will be indicating that the person is having adenocarditis, and these are the positive sign and person is diagnosed with adenocarditis. The capsule thickness in the axillary rhesus and the rotator interval or the rotator cuff interval that was strongly and significantly related with the range of rotational external rotation. So these are the three signs which we have to assess. So this is the thickness of the axillary radius. We have to assess this area. We can see here, this is that thickness. If it is more than 4.5 millimeter, that will be considered as the positive sign for the radiosecondary. Similarly, this black area, which is this actually the rotator cuff interval, this is supraspinatus tendon. These are the posterior cuff muscles. This is the subscapularis muscle, and this area is known as the rotator cuff interval. So, if the thickness of this rotator interval is more than 6 millimeter, it will be considered as a positive sign for the adhesive capsulitis. Similarly, here we can also assess the thickness, the width of the this interval. This is the superior, we can say this is the superior end of the subscapularis, while these are the interior fibers of this supraspinatus. So the distance between these interior most fibers of the supraspinatus as well as superior fibers of the subscapularis, this complete width, it is considered as the width of the subscapulator interval. So we are going to assess the shortest distance. You can see here, this is the longest distance on the periphery, but we have to assess here the shortest distance. So this is the humeral head, the round structure here, this is the humeral head. So near to the humeral head, we can see it's also the longer than the midpoint, and the peripheral most area is also most longer than the mid portion. That's why this mid portion, the shortest distance between the superior, we can say that the superior border of the subscapularis, this is the subscapularis, and this the supraspinatus interior fibers. So the shortest distance between them is made and will be considered as the width of the rotator interval. This is equally the capsular thickness as well as the rotator interval. A rotator interval is measured as the distance between this is the longest, we can say that the thickest portion which is present between the supraspinatus interior fibers and the subscapularis superior fibers. So the thickest portion is being measured. And these three signs, along with the subcoracoid triangle observation, which is known as the subcoracoid triangle sign, these are the characteristic abnormal features of the elliptical threads and the MR. The thickness of the capsule of the axillary radius is best demonstrated on the coronal images at the mid-glenoid level. Because at the mid-glenoid level, we can see here the axillary radius is best viewed at the mid-glenoid level rather than on the peripheral images. So we can see here this is actually the thickness of that axillary radius. This is the glenoid cavity. This is the scapula. This is the humeral head. This is sagittal oblique, and this is the coronal proton density image. It is best seen in the. This is the best image for use for the assessment of the thickness of that axillary radius, and this is the best. The sagittal oblique proton density image is the best view at the mid sagittal level to see versus thickness of the humeral ligament. Here the distance is 5.3 millimeter, and here the distance at 13.8. In both the case, it is a positive sign for the adhesive. The oblique coronal plates related elevated image shows giant capsule edema. That whiteness, the hyperintensity, that is edema. This is the extra capsular edema present at the lower part of that giant at the area of the axillary radius. This is the opioid sagittal fat suppressed. What we mean by the fat suppressed is a specific sequence of the MR in which the signal from the fat that is being diminished, or we can say that there is no signal back from the film back from the fat. So the signal from the fat and lipid that's up. Otherwise, if it is not the fat suppressed, so if the fat and lipid, if they are present there, they will be look brighter. They will be hyper intensity. But in the fat suppressed, the brightness or the hyper intensity, they will be just from the in a liquid medium present there. So again, this is the edema, which we can see here at this illustrator cloudiness at the here in the two weighted images on the posterior side of the giant the extremity of the edema. This is the oblique sagittal T1 weighted MR image shows the complete obliteration of the subcortical triangle. This area, if there was normal subcortical triangles, it will be look brighter, just like this area, because they are look brighter on the T1 weighted images. And other than red, nothing can be viewed as brighter. All other things they will have hyper intensity except the red show the hyper intensity. But there is no such brightness in this area, which is the anatomical site for that subcortical triangle, which means there is complete obliteration. Obliteration से मुराद ये है कि मुकम्मल खत्म होना, इनके नाम और निशान भी ना हो, that is known as obliteration. The axial fat suppressed T2 MR image show fluid in the long head thoracic tendon. This is that tendon, the bicep tendon, long head of the bicep and the surrounding of that tendon. This is the sheath. This is that edema, right hyper intense. And it is T2 weighted, so that's why the inflammation or the fluid or the edema they look brighter. If it is for T1 weighted, so there will be no such brightness hyper intensity. There are two views of the MR. One is the axial view, the other is one is the sagittal. This is the sagittal view, and this is the axial view. So now, what are the practical findings which we can have during the subjective and the objective examination of the patient with hepatitis? If the patient is in the acute stage and the condition is very severe, then he will be excessive skeptical perfection. Mobility, the range of motion, they will be severely limited. They will be excessive stability thoracic giant motion, a common characteristic of elevation, which will be present as we discussed earlier. The patient जब elevation करेगा तो 60 degree elevation से पहले जो है earlier start of the scapular movement शुरू हो जाएगी. Similarly, जो इस patient का range of motion है वो एक तो range of motion वो restricted होगा. And mostly this is the lateral rotation or the external rotation and abduction. ये commonly restricted होगी और sometimes जो है इसमें flexion as well as the internal rotation वो भी जो है limited हो सकते हैं. The medial rotation or the internal rotation is commonly limited and behind the back are the reported limitation. Otherwise, there may be not the common restricted motion in the patient with. Similarly, if we assess the linear motion isolatedly, so they all will be limited and typically 50% limited and distant from the normal. Normal, these are the ranges of the normal linear passive range of motion, which is 120 of friction, 120 of deflection, 90 of the lateral rotation, and 70 of the medial rotation, and 90 of the abduction. The glenohumeral accessory movements and joint plane movements, they are also considerably limited, specifically the humeral inferior posterior and anterior transmission. In the acute state, the symptoms they are worst, they are severe at end range position, because this end range position will put the scapula and the ligament into the maximum stage, which will lead to the exaggeration in the symptoms, lead to the extreme pain. Similarly, the rotator cuff muscle they will be weak or bent due to rotation transmitted when inflamed joint full. We have discussed this mechanism in detail in the previous section. Now, initially there is इन्फ्लेमेशन होती है, उसके बाद स्टिफनेस होती है, और ये कैप्सूल एंड लिगामेंट स्टिफनेस जो है ये फिर मुंतकिल हो जाती है, ट्रांसफर हो जाती है, ट्रांसमिट हो जाती है इनटू द रोटेटर कफ टेंडन, which will eventually become weak or there will be pain, and sometimes वहाँ पर भी inflammation हो सकती है and tendinitis है हो सकती है. So these tendinitis and the rotator cuff muscle that is secondary to the that inflammation and stiffness in the glenohumeral joint capsule and ligaments. So this transmitted to an inflamed joint capsule by contracted musculotendinous unit that attach to the capsule. Pain around the joint capsule present होगा and it's near the axillary जो है वहाँ पे pain की patient. If the condition is in the moderate and that means there is more than 3 weeks of that condition, that is subacute condition. So all the impairment of the mobility, they will be in the moderate way. Registered test, they may be normal, they are strong and relatively painless in the clinical joint condition and the mid range, because the tension in the metal process is being subsided and the tension in the capsule has been declined. Now the patient is in the subacute stage, so the patient can be assessed for the comprehensive examination of the different regions of the upper body. And impairment should be assessed like for the cervical disc lesion or for the other muscles related to the surrounding of the scapula and as well as in the shoulder. Segmental movements in the immunities, they may be present in the cervical and upper thoracic spine. Similarly, the physiologic and accessory both movements that will be still limited. Muscle flexibility may be present, the muscle deficit in the muscle flexibility present, and specifically the muscles which will showing some tightness when they are going to stretch. They are the muscles which are, may be involved are the subscapularis, the spinatus, the pectoralis minor and the pectoralis majoris dorsi and the teres major myofascium. These all are the muscles which are present in the surrounding of the that shoulder joint and scapula. Similarly, यहाँ पे thoracic outlet syndrome में nerve mobility deficit हो सकते हैं, and these nerve mobility deficit may be related to the medial, bradal, and ulnar nerve entrapment in the thoracic outlet. The scapular upper rotatus muscle, they are most commonly weak and which involve the lower trap, the middle trap, and as well as the serratus anterior. There is excessive scapular elevation, and not only excessive scapular elevation, there is early elevation of the scapula as well, and the abduction and the downward rotation are winging with the pitch. When it is in the chronic stage, the mild condition, the set stage, so all the impairment in the mobility, they are now at the mild intensity, and the pain with is only present with repetitive activities and specifically at end range. Otherwise, in the single executive movement, there may be no such pain. Pain only when lower pressure at range is lower pressure is provided applied at end range. Otherwise, normally, if the person is doing any active movements, there will be no such movements. The remaining, which we discuss in the moderate case, when the condition is the subacute, so all other characteristic sign and symptoms like the moderate case. So, what are the intervention approaches and strategies we can have as a therapist for the patient with adhesive capsulitis? So we have to assess the patient is in the acute stage, the subacute stage, or the chronic stage. If it is in the condition is very severe, so mostly our goal is to control and subside the pain, or mostly our focus will be on the pain management. While if in the subacute stage, when the pain is declined, subsided, so mostly we will work on the muscle tensing and the muscle stretching, as well as we can also work on the improvement in the range of motion, because now the pain is in the variable condition, so we can work on the management of that range, the range as well as the muscle. So it is very important to decide that the patient is in the acute, subacute, or chronic stage, because every stage has different goals. If the patient is in the acute stage or in the severe condition, our goal is to prevent movement-induced inflammatory reaction, divide muscle guarding, can be with daily activities that use shoulder within the available range, and the sleep, undisturbed sleep without pain. So what we can use, what we can have, what are the strategies which we can have? So we can use the uh, physical agent like the process and the inoculation, or the pulse ultrasound to assist the reducing the. And this pulse ultrasound is very important in the declining or in the reducing the inflammatory symptoms. Similarly, we can also use the cryotherapy, the ice or the TINS for the relief of the pain as well as to reduce the muscle guarding or the muscle guarding induced spasm. Tapping and splinting are the orthotics devices. They can also be used in the acute stage as an external device just to heal that patient and just to reduce the inflammatory signs. Especially the tapping can be used because the tapping they have some physiological, it improves the circulation, it improves the lymphatic drainage, so they all will lead to the decrease, may have an indirectly effect on the decline in inflammation. But patient with the sling if pain relief requires stimulate use up in the external device. Similarly, different range of motion or the basic unit exercise can be prescribed and when be added to the protocol for the that acute stage patient in the therapeutic exercise. The pendulum or the Cordman exercises, they are very important, they are very crucial, and these that should be provided to the patient to increase the range of motion and have as they have also an effect on the decline and similarly, we will also educate the patient to avoid and to protect them from the way injury. So we will have to limit the entering motion or stretches, overhead or behind the back activities because all these activities will recreate and aggravate the patient condition. This is the Cordman exercises. The person will have to move the hand in a circular motion and it will be hanging in a downward position while the other arm will be used as support on the table or on the chair or the other thing. If the patient is in the subacute stage, in the moderate condition, the goals will be we have to work on the range of motion, we have to improve the scapular rhythm, and also we have to work on the strength of the muscles and uh, to, to avoid or to protect the joint from the region. The main goal in the subacute is the range of motion, as there is some subsiding, the pain has been subsided in this state. So that's why now we can work on the range of motion and the strength of the muscle around the shoulder and hip. Ultrasound can be used just before or it can be used after the exercise as well. But earlier to the exercises, that is very beneficial. Soft tissue mobilization that can be used for the muscle which have been flexible. And joint mobilization is also can be applied to restricted accessory and joint play motion. And these joint mobilization, uh, still requires they are very crucial for the increase in the range of motion exercise. And sometimes we may have immediate effect. We have the immediate improvement in the range of motion if they are provided in the proper and appropriate method. Stretching exercises in the therapeutics, we can prescribe them for the muscles which have been tight, which having the muscle flexibility deficit, which we have mentioned in the previous slide, what muscles they are most commonly present with the flexibility. Similarly, strength exercises for those muscles which are weaker, specifically the upward rotator, the upper trap, the lower trap, and serratus anterior. These muscles they are very for weak. Strength exercises can be executed for these weak muscles as well as for the scapular depressor, which is the lower trap and the rotator cuff motion. These are the different literature evidence which support the strengthening and exercises for these muscles, and they have a very, they are very effective and very significant for the improvement of the symptom. These are the different exercises which can be used for the shoulder. Like we have the one exercise which used in the flexion and extension, they can use in the both. Similarly, there is then the external rotation in the supine position. There is active range of motion exercise for the flexion. This is the one exercise for the internal rotation. This is the one exercise. Is one simple mean a long stick. Even a wicket can be used, a pipe can be used. 1 inch pipe that is most proper for this, because the mechanism why this stick is used, बिकॉज एक शोल्डर में अगर पेन है और पेन की वजह से जो है वो इसको एलिवेट नहीं कर मूव नहीं कर सकता, दूसरा शोल्डर जो नॉर्मल है ये इसको फैसिलिटेट करे, बिकॉज बोथ क्योंकि बोथ लिम्ब जो है ये क्लोज काइनेटिक में होंगे, दोनों जो है उस स्टिक को उन्होंने पकड़ा होगा, सो दैट्स व्हाई जब एक शोल्डर को मूव करेगा वो अपने साथ जो इन्वॉल्व पैथोलॉजिकल शोल्डर है उसमें भी जो है ये मूवमेंट काज करेगा. So this is used for the abduction and adduction as well. This is the pendular exercise, the Codman exercise. And if the patient can bear, so यहाँ पे weight भी हम दे सकते हैं 500 ग्राम हम दे सकते हैं, या हाफ के जी या 1 kg तक वेट जो है यहाँ पे होल्ड करके, and if weight is not available, we can instruct the patient to have a bottle of water. तो यहाँ पे वो हाथ में होल्ड करेगा और फिर इसमें सर्कुलर डायरेक्शन में इस तरह सर्कमडक्शन में ये इसको मूवमेंट करेगा, दूसरे हाथ से टेबल पकड़ के इसको सपोर्ट के तौर पर यूज करेगा. स्किपुलर एक्टिव रेंज ऑफ मोशन एक्सरसाइजेस हम पेशेंट को दे सकते हैं. पेक्टोरलिस और स्ट्रिक्स, स्पेसिफिक द पेक्टोरलिस माइनर स्ट्रिक्स जो है ये दे सकते हैं. पेक्टोरलिस माइनर स्ट्रिक्स जो है ये थेरापिस्ट जो है सुपाइन में भी दे सकते हैं कि वहाँ पे पेक्टोरलिस माइनर की जो टेंडन है या वहाँ की जो मायोफिशिया स्टिफनेस है वो रिलीज भी कर सकता है, इसके बहुत अच्छे इफेक्ट्स आते हैं. बाइसेप स्ट्रेच जो है ये दे सकते हैं. एंड टॉवल एक्सरसाइजेस आर द बिल्डिंग. टॉवल एक्सरसाइजेस दे आर वेरी important to improve both the external and internal rotation. So this is the we can call is the scarf test, and it is across the body stretch, and it used when there is internal rotation deficit, because this exercise we will be stretching up the posterior capsule, and it is very beneficial. The sleeping stretch they can also use for the same purpose. These are the same exercises. We can use the pulley as well for the improvement of that range of motion. So during the active range of motion exercises, the pulley exercise, they can use arm circle for that active range of motion. Of the scapula, they can arm stretch, the towel stretch, the cross body arm stretch, we discussed in the previous slide, as well as the quad stretch. These all are the simple stretches for the shoulder. In the subacute stage, when the condition is moderate, we can also provide the neuromuscular rejuvenation, which will eventually facilitate the neutral thoracic cage, the scapular position, and shoulder, and improve the shoulder proprioception. Similarly, we can also work on the ergonomic aspect, promote efficient pain-free motor control of the trunk, scapula, and arm with the overhead activities. We can modify the activities with overuse and range. Now, if the patient is in the chronic state, in the mild condition, and all the symptoms they are in the mild intensive stage, our goal would be to decrease that stiffness and to normalize the glenohumeral range of motion, to normalize the upper quadrant posture, specifically the positioning of the scapula, the muscle flexibility, specifically the upper trap, and serratus anterior, and the muscle strength, the muscles which are surrounding the scapula. The muscle strength, the muscles which are going to be weak, they are serratus anterior and the depressor of the scapular lower trap, and the muscle which are most, they will be flexible, they will be subscapularis as well as pectoralis minor. All these supraspinatus, infraspinatus, all these muscles, they will maybe having some flexibility problem. And I can have the goal maybe to have tolerance. So what we can do in the manual therapy section, we can increase the intensity and duration of the stop mobilization, which the patient will already was receiving when he was in the moderate condition, and the myofascial stretching to the maximum tolerance level in the steady state. Similarly, the intensity and duration of the joint mobilization can also be increased to the maximum tolerable level. These are the different literatures which can be supporting the use of the minimal therapy and psoriasis. And all these are supporting the statement that mobilization is very significantly effective in the subsiding of the symptom of the This is the sleeper stretch, which is an alternative for the posterior capsule tightness. In the therapeutic exercises, we will maximize the muscle execution of the relevant scapula, flexion, and shoulder girdle muscle, which are required to execute the desired occupational and recreational activities. This is another option which we have that is very uncommon in the Pakistani and Indian population therapist practice, but that is is commonly used in the Chinese and the Korean therapies. Sunna manual therapy, this is the Korean manual therapy technique, and systematic reviews are present which are supporting the effectiveness of Sunna uh, manual therapy for the decline of pain and for the others decline subsiding of the symptoms of infection capsulitis. Similarly, evidence is also supporting the higher intensity laser therapy, uh, and they are very effective in the declining the intensity of the pain and obviously to improve the quality of life. But they are just useful and for these two outcomes, the pain and quality of life, there is no such significant effect for the uh, improvement in the disability or the function of patient and the patient within. Dry needling can be used to release the symptoms of myofascial trigger points, and their technique may improve the pain, range of motion, disability, and pressure. When threshold along with the conventional therapy, they can be used in combination with other options, and evidence is present in the support of the use of these dry needling for the myofascial trigger points. Acupuncture, they can be also used along with other conventional physical therapy technique. Uh, and they have showed and revealed the severe effectiveness with respect to the time course of the recovery process in endometriosis. Different literature is there supporting the use of acupuncture and along with other conservative therapy in the patient with endometriosis. This is a new technique which is not common in practice in the subcontinent, the B-venom acupuncture. And studies, even systematic review and meta-analysis, they are supporting the effectiveness of B-venom acupuncture. And studies have shown that the B-venom acupuncture may an effective way in treating shoulder arthritis. So in these are the three review studies. This is the systematic and meta-analysis, systematic and meta-analysis, and this also review, and all of them they are just assessing the B-venom acupuncture for the arthritis. So one study was, and mostly these are being practiced in the Chinese and Korean, and specifically in the Chinese population, Chinese therapists. The B-venom acupuncture for adult capsulitis is the protocol for systematic meta-analysis. The effectiveness of B-venom acupuncture and treating the post-stroke shoulder pain, and specifically shoulder pain, as we have discussed earlier, there adult capsulitis that is very prevalent among the patient with CVA among the after the stroke because they will be unable to move the joints in the anatomical in the maximum range of motion. That's why stiffness जो है ये उनकी shoulder में develop हो जाती है जिसकी वजह से inflammation appear start as radiculitis. The next study is the B-venom acupuncture for the musculoskeletal pain. So though that is not specific for the adhesive capsulitis, but again as the heterosexuality span is the most genital span, so it means it is also an evidence supporting use of PV of acupuncture. Similarly, pulse radio frequency, which is being guided through ultrasound, again, there are several studies which are supporting this ultrasound guided radio for the patient have reduced status. And the findings of this study, which is the randomized control trial of ultrasound guided pulse radio frequency for patient with frozen shoulder, the recent 2019 study. The finding of this study showed that the ultrasound guided pulse radio frequency may benefit for patient with frozen shoulder after 12 weeks treatment. These all are the different studies which are the which showing the effectiveness of the ultrasound guided pulse radio frequency in the patient with diabetic arthritis. So this study is the effects of ultrasound guided suprascapular nerve pulse radio frequency and chronic shoulder pain, the effectiveness of pulse radio frequency on the joint pain, ultrasound guided pulse radio frequency stimulation for scapular nerve of diabetic arthritis, and treating the shoulder with ultrasound guided pulse radio frequency. So all these are the studies which having which showing the very significant effectiveness of the ultrasound guided pulse radio. These are the general references which students can read them for the further reading for the better understanding of the hereditary capsulitis and all the common concepts and how to assess, how to treat, how to diagnose the hereditary capsulitis. So all these studies they can help them. That was the end of the today's session. Thank you so much to all of you. Have a nice day. Allah.